My name is Victoria Nesbitt. I'm clinical lead for the highly specialised services in Oxford. I'm a consultant paediatrician and clinical lecturer, but I work with both adults and children. Um, Primarily, I do kind of family-centred care, but often I will follow young people right through into adulthood, and then end up with additional family members through them. Sue, you're similar. Do you want to introduce yourself?
Hi everyone. Uh, when Dr. Nesbitt says I'm similar, I'm definitely not a doctor. So hi to everyone. It's nice to see some familiar faces as well. And I joined the mitochondrial service 5 and a bit years ago now. And obviously, like we all work together as a great team, but it's so lovely to have the Lilly Foundation on board as well. And they're always helping us with things. And as you know, as patients, they're so inclusive of everybody. And it's just really lovely opportunity to be able to do some of the kind of talks like this, and then we can obviously get questions from the floor and hopefully help get some answers to those. So really nice to be here. Thank you.
Thank you. So we're going to be fairly optimistic in what we can try and cover tonight. Some of these things were suggested to us by Liz and by Katie, I think, from yourselves. Some of the things are things we've been asked before by patients that come to Oxford. So we've tried to put it all together. There is quite a lot to get through. So some of it might feel a little bit superficial, but if there's questions related to them, like Katie says, just pop them in the chat or pop your hand up and we'll do the best to answer them. The three centres, so Newcastle, Oxford and London Queen Square, are commissioned services. That means we're funded differently. It does, however, because we work for individual trust, there is some slight variations in the way that practices are done. So we'll try and kind of cover what all three do. In addition to that, we've got several other large tertiary hospitals like Cambridge and Bristol and Great Ormond Street and Manchester and Glasgow, who are also providing mitochondrial care, and we work quite closely with those. So we've got a very good professional network in this country, which we're very fortunate to have. If we think a little bit about you, can you see that? Because it wasn't working for Sue previously. Has the picture come up, Sue? Oh, good, excellent, good. So for some of you who are newly diagnosed, you might have been feeling quite isolated and quite alone and have been going to and from your GP for several years before you've ended up with your diagnosis of mitochondrial disease. And then suddenly there's this influx of people who have come into your life and they're all there to support you, but it can feel extremely overwhelming. Now, this is probably important for me to say at this point. Don't worry if you haven't got all of these people involved in your life. It does not mean you need them all. It's just the ones that you potentially will come across following a diagnosis of mitochondrial disease. We talk a lot about staying healthy and living well, and part of that is our responsibility as your clinical teams to help put in place some general surveillance that we like to happen to make sure that we identify any associated problems early, and try to slow the progression of anything that comes on. I'm aware that some of you in the room are adult patients and some of you are parents of children. So again, we're going to try and cover both of those things as we talk through the slides. Growth and nutrition is one of my favourites. So if we aren't healthy in our bodies, then it's very difficult to fight off disease and to have enough energy to do the things that we want to do, in addition to having a mitochondrial condition. For children, failure to thrive or faltering growth, they're the terms that are often used. That's something that is often seen from a very young age in children that are affected by mitochondrial conditions, but is often not recognized as being associated with a mitochondrial condition until something else happens. For the adults, it might be that you've really struggled to gain weight over the years. And again, that's not uncommon. And if we think about it in a logical fashion, then actually your mitochondria are working extremely hard to convert the food energy that you eat into the chemical energy that you need to grow and to function, and just get about your day-to-day life. There's not lots left over to help you put a bit of weight on, essentially. So it can be very, very difficult. Sometimes we have to intervene and help get some more calories into your system, and that might be by a feeding tube. And I think people often think that feeding tubes are really just there for people who can't swallow. But actually, they're not. They can be a really helpful, particularly what's called a gastrostomy, where it goes directly into your tummy. They can be extremely helpful for people who are really struggling to gain weight, as a way of giving supplementary feeds. That's something that your clinicians might mention to you, and certainly in Oxford, we do talk about that quite early on for those people who are particularly have very low BMIs, body mass index. And it's not something that you need to fear at all. I think historically, gastrostomies and feeding tubes were associated with end of life type situations or extreme ends of illness, and that's really not the case at all. We're very much about preventative medicine, and therefore, if that's a way that we can keep you healthy and stronger for longer, then it's something that we might suggest. I'm going to talk a little bit later on diet, although I'm not going to spend too much time on that, as I know that you've got Chantel, our specialist dietitian, coming along to one of these in the autumn with Claire, our speech therapist, to talk about that a little bit longer. But just a couple of top tips that we'll go on to later. Cardiac, so that's your heart. Lots of mitochondrial conditions are associated with problems of the heart, and that might be with rhythm disturbances, so an irregular heartbeat. Or it might be that the muscle side of the heart, the chambers that pump the blood around the body, start to get a little bit thickened and then a little bit stiff. It doesn't happen in all mitochondrial conditions. It's usually something that we like everybody to have been assessed for right at the start, either in the journey of trying to find your diagnosis or once you're diagnosed. And then depending on your individual variant, your genetic mutation will dictate how often you need your heart screened. And heart screening, again, that tends to typically be an ECG, so that's the stickies on your chest, and it might be that it's done as a standalone test, or much more preferably to us is one that you wear for 24 hours, so that you get a good picture as to what's happening both day and night with your heart rhythm. That does the electricity part of your heart. And then an echo, and that's the ultrasound. So ladies in the room who've had babies, just the same as you would have had when you were pregnant, but up on the top part of your chest, and it gives us a super view of how your heart is beating and the blood flowing through it. Much more novel, but becoming more widely used, is a cardiac MRI. So the scan, where you go in the tunnel, the big clunky tunnel machine that is there to look at the heart. Now, not all centres are able to do that. It is still relatively new, but it again can, if your local cardiology service offer that, that's often something they will do, as it gives much more detailed information that can be super helpful in allowing us to pick up that thickening just that little bit earlier and offering you medication that could slow down the progression of that disease. Audiology is your hearing. Again, for a lot of our children, we like them to have a hearing test done right at the start, or when we're first deciding whether or not they have got a mitochondrial disease. For adults, we tend to ask you about your hearing in your clinic appointments, and it will be two things we'll ask you about. One is your outright hearing. Have you noticed any differences in your hearing? Sometimes we ask your partners, because that's often a better way to judge whether or not there's been a hearing loss. But we'll also ask you about whether or not you've got any buzzing or ringing in your ears, so tinnitus. And that can be the first sign that your hearing is just starting to deteriorate a little bit. Our quality of life is affected massively by our ability to hear and to communicate with others. So again, it might not be something that we can cure, but again, technology has brought on hearing aids in a hugely positive way over the last few years. That's something that can make a huge difference to the quality of your life. Similarly with vision, we know some of you, and I can see some of you on the screen, that do suffer from ptosis, so the drooping of your eyelids. Or it might be that you've got restricted eye movements. That means your eyeballs don't move when you want them to look one way or the other, and that's not uncommon in mitochondrial disease as well. Sometimes that's the first thing that's been picked up. You've gone for a routine eye test, and actually your local optician has said, "Oh, I don't think your eyes are moving quite as in the way we would expect." So again, we like you to keep up with your standard vision assessments, again, from a quality of life perspective. It's one of our senses. We want it to be as best it can be. And of course, it's quite trendy to wear glasses now as well, isn't it? Diabetes, very, very common condition, type 1 and type 2 diabetes. Type 1 typically require insulin injections. Type 2 can usually be managed, sorry, by diet and by medication, so oral medication. Again, sometimes that's the first thing that occurs in your mitochondrial journey, and that's how you've been investigated. People who have a mitochondrial DNA variant, so if you've been told that your mitochondrial disease is due to a condition that starts with M dot, that means it's a maternally inherited mitochondrial DNA variant. We like you to have a diabetes check every year. And again, if we can manage diabetes, we can prevent complications much, much quicker and keep you going with a good quality of life. Bloods and urine. I think sometimes people wonder, you go to the doctors and you end up with some tests. Well, what are you having these tests for? When we're doing your bloods and your urine checks, we're particularly looking at your hemoglobin levels and your iron levels, so looking for anemia, because that can happen with any chronic disease, not just with mitochondrial disease. But primarily for us, we're looking at your kidney function and your liver function. And again, we're trying to pick up early changes before any symptoms of any complications or disease manifestations have occurred, so that we can slow that progression or try and do something about it so it doesn't actually affect you in your day-to-day life. Your mental health is very important, and we're very lucky to have the Lilly Foundation to support people affected by mitochondrial disease. And of course, they've partnered with Rare Minds as well, who are able to offer some bespoke mental health support for some patients. But if you're ever worried about your mental health, even either in the context of your diagnosis or other, because nature is cruel. Just because you have a mitochondrial disease doesn't mean you can't be affected by other things, both physical conditions and mental health conditions. Then it's really important that you speak to your GP. If you're struggling with that, then again, reach out to one of us, reach out to your local clinician or to the Lilly Foundation, so that we can try and help put support in place. We know that we have to keep our minds healthy in order to keep our bodies healthy as well. And cognitive functioning. I love a bit of cognitive function in me. I love knowing how people learn and think and develop, not just from a pediatric point of view. I think it's fascinating in adulthood. Some of our mitochondrial conditions, particularly if they've been associated with stroke-like episodes, metabolic strokes, can have an impact on the way that we do, that our brain works thereafter. And it's often a good way of seeing what the deterioration has been and whether or not it's plateaued or the likes. In children, it's used often more commonly to help support education. So the educational psychologist might do it if a young person is applying for an education healthcare plan. For those of you who are a little bit older, that's similar to the old statement of special educational needs. That used to be, but it's a much more holistic and encompassing support plan that's put in place now as well. Like I said, there's three nationally commissioned centres, but lots of other super centres within the UK, and we collectively work together to write best care guidelines for people affected by mitochondrial disease. This is a list of, actually not all of them, I've just realised not all of them, that are on there. These are publicly accessible. So these are not private documents. These are things that if you go onto the NHS Mitochondrial Diseases website, you or your local doctors can access all of these things. They are all currently under review, because actually it's quite a long time since we've written a lot of them. So myself and Bobby McFarland and Andy Schaefer and Rob Keithley are ploughing our way through them to try and make sure that evidence hasn't changed since we wrote them, because some of them were actually written kind of 8 years ago. So far, it doesn't look like there's any massive changes to be made, but we'll keep going to make sure that we are up to date with the latest evidence and that we are giving the best advice to you and to your local teams. Like I say, just have a look on the website, because they are publicly accessible. We were asked to talk about medications to avoid, and I guess ones that are safe to use as well. It is probably one of the most common questions that we get asked from local teams. And I love the fact that GPs and local teams are actually thinking about, could this medicine affect you and your health? So that's as far as I'm concerned, it's a really positive thing. I think sometimes local teams get a little bit frustrated with us that we don't reply to them quick enough, but we get such a huge volume of emails and letters coming in. It's sometimes not quite as simple as you would think. I'm going to draw your attention to the bottom of the screen first before I kind of start and work through them. Again, this is a publicly accessible list that can be used. So do take note of that. It's available on the Lilly Foundation website. And often something that we will put in your clinic letters so that local doctors that are working with you can see the list of medicines that we feel are safe to use and that they are you should avoid. There's actually very few medications now that we will strictly ask you to avoid. It's changed hugely over the last 5 years even. Yeah, I've been doing mitochondrial medicine since 2008, and actually there was a huge list of drugs that we used to ask you to avoid in that time. But actually there was an international consortium got together. So Bobby McFarland, Rob Pitt-Keithley, Yi Ung, I'm trying to think who else from the UK was on that group. Rita, I think, possibly was as well, Rita Horvath. So there was 16 experts in mitochondrial medicine from across Europe were brought together to have a look at the list of medicines that were previously regarded as unsuitable for patients with mitochondrial diseases, and they looked at the evidence of them to pull up a much more updated and evidence-based list for you all to be able to use and for your local teams to be able to access. And like I say, there's actually very few medicines that aren't safe to use in mitochondrial conditions. So the two, Sue reminded me earlier when we were going through our slides, Sue really reminded me of the two that were probably asked most commonly about are statins and ibuprofen. Statins are used to lower your cholesterol, and historically mitochondrial patients were told not to be put on statins. And the reason for that was it was felt that it would increase the lactate in your body and make you unwell, essentially. We know that's not the case for the vast majority of patients, and actually statins can do that in people who don't have mitochondrial disease as well. So our general rule now with statins is that if your doctor is prescribing you a statin because your cholesterol is at a level that it is posing a risk to your health, then the benefit outweighs the risk. I'm probably still a little bit old school, I'll be honest, and I will often say to GPs, well, check their lactate, check their muscle enzymes, and check their kidney functions before you start, and check it again in 3 months' time. And ultimately, if that's changed or deteriorated in any way, we'll have another conversation about whether or not the statins should continue or whether or not there's something else we should be trying. So that's definitely there. That's my own practice rather than an evidence-based practice, I would say. So not all of the other centres will do that. Like I say, I think I'm just being overly cautious in that sense. Ibuprofen, again, that was another one that was previously reported to potentially cause deterioration in patients with mitochondrial disease. We now know that's not the case. The only time that you really need to have a little bit of caution with ibuprofen is if you've been told that you can't have it for another health condition, or if you've got kidney involvement. So ibuprofen is actually broken down by your kidneys rather than your liver. And so if you've got kidney problems, it might be that you're not allowed it for the potential risk to your kidneys, or it might be that you need a reduced dose of that medicine. But again, and particularly for children, when you're struggling to control a fever, then it's an extra to Calpol, to paracetamol that you can use. Medications that we know that can create problems. So sodium valproate, in those of you who have the POLG disorder, so polymerase gamma, it's a wide spectrum of mitochondrial disease that affects from babies right up to adults, and a huge array of clinical features that you see associated with it. We ask for sodium valproate not to be used for people with POLG. Sodium valproate, apologies, it's an anti-epileptic, so a drug that's used for seizures. And we ask for it not to be used because we know it can seriously and irreversibly damage your liver. It's less of a problem in the adult group. Certainly in children, sodium valproate is a fantastic drug for controlling seizures. But we ask all of our pediatric colleagues when they're trying to manage epilepsy not to use sodium valproate until they have excluded Pol-G in that child. Like I say, just for the irreversible liver damage that can be caused. Gentamicin is an antibiotic. You get gentamicin ear drops commonly. Otherwise, gentamicin is rather unfortunately one of the first line antibiotics that are used in neonates, so the newborn babies. So newborn babies that are born with a suspected infection, even in themselves or in their mums, might be put on a penicillin and gentamicin because they are superb at killing those bugs that could be causing the common things that cause newborn infections. Unfortunately, if you have the variant of M.1555, don't know how many fives I did there. Should be three fives. 1555 is what we usually say so that we don't lose track of the fives that we've said, which typically can affect your hearing. Then actually using gentamicin can cause hearing loss. So that's why we ask for that not to be used in that condition. The key thing when you're being prescribed a new medicine by anyone is that they check the interactions just the same as they would any other drug. So it doesn't matter what condition, what health condition you've got, your GP or your hospital doctor should be looking at your normal list of medications and making sure that there's not any interactions between them, because sometimes they can do funny things to one another. The same goes for over-the-counter and herbal remedies. There's a huge misconception that because something is herbal or natural, that it won't cause any side effects. Plants are probably one of the most dangerous things in the world. They're one of the most poisonous species that we actually have. And whilst they can do lots and lots of good, they can equally do lots of harm. So be very careful when you are seeking herbal remedies for conditions, mitochondrial or otherwise. Just be a little bit cautious. St. John's wort's a really good example of that. St. John's wort is a superb herbal remedy, but actually it can have catastrophic effects on your heart. So again, it's really important that you discuss that with your GP if you're thinking about using more natural remedies. When you're buying something over the counter, just check with the pharmacist. That's what they're there for. I think our pharmacists are underutilized. They are hugely experienced and knowledgeable about these things. And if they don't know, they will find out. So do check with your local pharmacist before using an over-the-counter preparation. The one that we ask our anaesthetists, so the people that put us to sleep when we are having our operations, is there's a certain class of anaesthetics called neuromuscular blocking agents. We don't particularly like mitochondrial patients being put to sleep using those things just because it can take you longer to come around from them. And again, it can increase the lactate in your blood. Sometimes it's necessary for other medical reasons, but we just ask for some extra monitoring that's being used in those. We'll talk, Sue's going to talk a little bit more about operations in a little while. But yes, take a note of that web address and pass that on to your doctor if they don't have it already. Immunisations and vaccinations. So for children, children should have all of their routine immunisations. Again, prevention is better than cure, and some of the childhood illnesses, some of them unfortunately that are making a little bit of a comeback because of immunisation levels being the uptake of people having their immunisations has dropped. We are seeing measles way more than we used to, and similarly whooping cough we're seeing as well. Both are completely preventable with routine immunisations, and we do advise that children do have their routine vaccinations. Obviously, if they're unwell at the time, just the same as any other child, if they've got a fever or they're under the weather, that's not the right time to have their immunisations because they're already fighting something. Just wait until they're well. For children and adults, we advise that you have your annual flu vaccine and then your pneumococcal vaccine when it is scheduled, so it's usually once every 5 years. And for children now, the chickenpox vaccine will be introduced from January 2026. We have got we have got a chickenpox guideline, which we used to have before the vaccine was routinely offered. They are offering a catch-up program, particularly for more vulnerable children and adults. So you can speak to your GP to see whether or not you are eligible for the catch-up program. It's 2 vaccines that are 3 months apart. And the idea is that Whilst it might not prevent chickenpox, it can significantly reduce the severity of chickenpox occurring. For those of you who are lucky enough to go on holidays to exotic destinations that require additional vaccines, please do have a chat with us. Or again, your pharmacist. We had a super pharmacist earlier this year who was just amazing. If I could have given her a job in the service, I absolutely would have. She was brilliant. And we had a chap who was going off to do some volunteer work in Africa, and he needed a whole host of vaccinations before his trip. And she was brilliant at planning them out for him, separating them out so that if he was unwell from one, he had time to recover, and he still had it on board before he went on his trip. She was totally fantastic. And I've got to admit, I myself had even forgotten that actually we can discuss our holiday vaccinations with our local pharmacy teams. So please do that. And again, we had great lines of communication with them when they weren't sure about something, so that we could look at the evidence together to determine whether or not the risk benefit of a particular vaccine was really there. Ideally, you want them given well in advance, because if you're going to react to a vaccine or have a delayed reaction, you don't want that to spoil your holiday. You do need to have a little bit of caution with anti-malarial drugs. They can interact with a lot of anti-epileptic medications. So again, make sure you speak either to your GP or to your neurologist or to one of us if you are on anticonvulsant medication and planning on taking anti-malarials. Treatment options. Now, I know that's not what this talk is about, but again, I thought I'd touch on some of the things that we often get asked about. So CoQ10, ubiquinone, ubiquinol, ubiquinol, all those kind of words. CoQ10 is absolutely justified for people who have a ubiquinone deficiency, so a CoQ disorder. We need to top up their levels of ubiquinone to try and get them back to normal blood levels to prevent the clinical symptoms that we see. Anecdotally, CoQ10 has been used for mitochondrial fatigues, the theory being that the CoQ10 kind of mops up the free energy and helps distribute it around the body, giving you that little bit more energy. Now, when I talk about energy, I'm talking about it in terms of fatigue. And for those of you who are unfortunate enough to suffer from true fatigue, you will know exactly what I am talking about. Fatigue is the overwhelming feeling of exhaustion that is not relieved by rest. Most of us suffer from tiredness, and you have a little cat nap and you feel a lot better afterwards. That is not the same thing. Fatigue is when it is impacting on your ability to function daily. We do try it in people. There's been a lot of pushback with ubiquinone recently. So historically, we had a little bit of budget, the three centres, to finance ubiquinone for certain patients with it. I think we all probably over the last decade got maybe a little bit excited in using it and thinking this could help with lots of different things, and then have all been asked to cut back on our ubiquinone use, which is desperately frustrating for some of you, I know. It is something you can buy over the counter. It's not cheap, I would say. But speak to your local team, speak to whoever it is that you see for your mitochondrial conditions, and see whether or not you are somebody that they would consider trialing ubiquinone. Typically, we ask you to do a 3-month trial to see if there's any difference in it. And if there's no difference, fine, we just stop it. Sometimes we do get people who say, oh no, I can't notice a difference here. And then 2 weeks later, we get a phone call to say, right, clearly there was a difference. I need that back. That's fine. That's fine. Complex 1 deficiency. So complexes are the machinery of our mitochondria. There's 5 complexes that generate the energy that we use. Complex 1 is the biggest of those enzymes, of those proteins. If you've got a complex 1 deficiency, then riboflavin might have some benefit. The evidence is weak, but there is definitely some evidence that suggests that it could slow the development or progression of associated cardiac, so heart changes. So sometimes when you've first been diagnosed with a complex 1 deficiency, we will put you on riboflavin whilst we're trying to work out what the genetic changes are. Pyruvate dehydrogenase deficiency. Some are exceptionally responsive to thiamine, so that's something that might be useful for that particular group of patients. And similarly, the ketogenic diet. Again, historically, the ketogenic diet was thought to have been a bad thing for people with mitochondrial diseases. We're learning a lot more about it, and particularly for children and young adults who are terribly troubled by epilepsy and have tried multiple drugs where it hasn't controlled their seizures, then we might try a ketogenic diet under specialist dietetic guidance. Idebenome is probably a whole other talk in itself. So you'll have seen on the news recently and on social media that idebenome is now going to be licensed for use in Leber's hereditary optic neuropathy. We are expecting, just checking the date, what is the date? Is it the 9th today? We are expecting on Friday to have more details from NHS England with regards to which patients will be eligible for that. What they haven't yet decided, though, is how it's going to be funded. So certainly in Oxford, we've had lots of emails in already from patients with Labours wanting, understandably, to try idebenone. It's not something that we can yet issue. So certainly the three centres have got a meeting planned this month to discuss it further, which we're going to take to the commissioners because they haven't actually given us any guidance on how it's financed. But watch this space. We are on your side. We are absolutely in your corner, and we will push it forward as quickly as we can do. Exciting developments for those with TK2 deficiencies, so nucleoside therapy, so replacing the parts of the mitochondria that need to be replaced. It's an oral medication. It is currently being used on an extended access program, so trialing in specific pediatric patients. We are currently working with NICE to see whether or not it can be made available on the NHS, and similarly looking at the evidence for adults who are affected by TK2 as well. So again, lots of exciting developments coming that way. Watch this space. Stroke-like episodes, for those of you who have the 3243 mutation or a POLG mutation, often you will be asked, or you will ask about L-arginine or taurine. So these are proteins essentially that a Chinese research group thought that there was a difference in using L-arginine for reducing the effects of stroke-like episodes. That evidence has never been able to be successfully replicated. It was a very small group, and part of the problem was, in order to have the best effect for arginine, you need really to be in a centre who can offer you L-arginine within an hour of your symptoms developing. It's just never going to happen. It's just never going to happen. The evidence after that is really poor for it making any difference. Some people will take L-arginine as a kind of daily supplement. Again, there's no evidence, unfortunately, that it reduces your risk or the severity of stroke-like episodes. Transcranial stimulation, again, there's lots of exciting promise for that. So if you're somebody who has POLG and you suffer from seizures, particularly the adult population, this is something that might be offered to you when your seizures are difficult to control and you're having repeated episodes of what's called status epilepticus. So that's the prolonged seizures that are difficult to break. It's just as it says, really stickies that go onto your head, and little electrical signals are passed through to try and minimize the focus of the seizures, and that can be very effective for some patients. Lots of research going on with drug repurposing. So that's drugs that we already know and that we use them for other things. So we know their side effect profiles and the likes, which is often a stumbling block when we're introducing new medications. So these are drugs that are already on the market being used for other things. And we're looking at different ways that they could be used to help patients with mitochondrial disease. And gene therapy is an exciting development that I am optimistic in my professional career we will see for mitochondrial conditions. Vitamins and supplements. I am very pro multivitamins. I am a pediatrician. For years, we always recommended that all children had a daily multivitamin for the first 5 years of life. I think because our diets and The likes have changed over the time. I would go as far to extend that right up until puberty. My own children still have daily multivitamins and they're 13 and 19. They don't get an option. They get one put on the breakfast table every morning. And actually in this country, everybody, all of us, should probably take a vitamin D supplement, particularly over the winter months. We don't get enough sun. We need sunlight to make vitamin D. Vitamin D can have a huge effect on our energy levels, so our fatigue and on our mood, as well as our bone health. So really think about whether or not that's something, again, very easy to buy just over the counter, and they're quite cheap as well. So that's not too much of a burden financially from that, but it's definitely something to consider over the winter months. Riboflavin and thiamine, we've already talked about. Ubiquinone, we've talked about, particularly if you are really suffering from true fatigue. Oral rehydration solutions and sports drinks. So I don't mean those horrible canned energy drink things that you can buy. I'm talking like a Lucozade Sport or equivalent, and Electrolyte or Dioralyte. A lot of patients will tell us that when they start to feel unwell or fatigued, they will have one and feel much better. The likelihood is that it's just that their biochemical levels, so your sugar and your salt levels in your blood have just got a little knocked off, and that's just helping to get them back on par. It's similar to, if you're becoming a little bit dehydrated. Yes, in the early stages of dehydration, water is absolutely fine, but actually if you pass a certain point, you need a balance of salts within that as well to help bring your hydration levels back up to normal. So if you are somebody who struggles, particularly in afternoons, that is something that you could safely try to see if it makes you feel any better. Mito cocktails are another thing that we get asked a lot about. This is primarily derived from our friends across the water in the States. It is one tablet that kind of encompasses a lot of vitamins and supplements. So, just taking one tablet rather than a whole plethora of them is always nicer. The problem is, not only is there insufficient evidence for a lot of the things that are in the mito cocktails, some of them you have to be really careful for. You will all well know, look around the screen now, no two of you are the same. It's not one size fits all, and therefore it's not one pill fixes all either. So then you've got to be really careful with these kind of things, that there aren't components within that could affect you or your particular mitochondrial condition. So things like creatine, a lot of people will use creatine and creatinine to help. But actually for some people that could be really problematic for your kidneys. It's not something that's licensed over here in the UK. The mito cocktail is not evidence-based at the moment. And it's actually, if you break it down, it's pretty much a daily multivitamin, some extra vitamin C, some ubiquinone, and then it might have some other things in it that you don't actually need. So you can get all of those things elsewhere. Diet and fluids. So not to rain on Chantel's parade in the autumn, she will talk to you about the importance of eating a balanced diet. It sounds really boring, doesn't it? But actually, we're ever so lucky now that the foods that we import and the foods that we have locally, you can really pretty much get anything to eat in this country. Ideally, you want things that are going to give you slow release energy during the day, so complex carbohydrates. So if you can opt for your whole grain pastas and rices as opposed to the white ones, which give you a much quicker peak in your energy levels, but then a fall as well. And balanced with protein, which is a great source of energy and a longer acting energy, as well as our vegetables and fruits for our vitamin and mineral supplements. Ensure good hydration. I think this is, Sue, would you agree? This is probably one of the biggest things or the biggest problems that we see in the clinic. People just don't drink enough fluids. Everybody's busy. And you get home and you think, oh, I've only had one cup of tea since this morning. Actually, that really stresses out our mitochondria. And actually what we're trying to do is prevent the stress on our mitochondria, and that's what helps us keep well. So really try hard to drink throughout the day. Again, it used to be that we used to say patients with mitochondrial disease shouldn't have caffeine because that places an additional metabolic stress. Actually, I'd rather you had caffeine than nothing at all. That's probably better than nothing. If you can choose decaffeinated options, decaffeinated teas, decaffeinated coffees, decaffeinated Diet Cokes, Sue usually brings me one of those into clinic, then that's definitely the way to go. Avoiding fasting and dehydration is key to staying well in mitochondrial disease. Not only does it make you feel rubbish, but actually it can precipitate some deteriorations in some of the mitochondrial conditions. With regards to food, eat little and often. That doesn't mean 6 massive meals a day, but equally, we don't want you to just have 3 big meals a day with these big gaps in between. So, actually, 6 smaller meals a day works much better for our metabolisms and certainly for those affected by mitochondrial disease. There was some interesting work done on low residue or low fiber diets, which can be particularly effective for some adults and particularly those who are really troubled with gastro symptoms, so constipation, bloating, flatulence, those things which can have a massive impact on your quality of life. Low fiber diets seem to be effective. It is something that should be done under dietetic guidance, but reach out if that's something that you wanted to explore further. You have definitely had enough of my voice. So I'm going to hand over to Sue now, who's going to talk you through a few more bits for living well.
I think you're on a roll there, Victoria, weren't you? We're all on a complete roll, and I'm going to be like, right, now we change tact. No. Moving on with what we were talking about, operations. It would be really lovely if you could just let us know, first of all, if you're going to be having an operation, if you're in our local hospitals. We do try and see our inpatients if you come in locally. But again, we're all different. Newcastle and London, we're all different in our team. So it depends what everyone's able to offer. But it would be, great for us to have on our notes that you're obviously planning to have an operation, and then we can be aware that the anaesthetist might contact us if they want any more information, or your clinical team. So again, try not to get stuck in between your clinicians and us, with them saying, can you contact and ask them this and ask them that? We much prefer to talk clinician to clinician, especially when it means, anaesthetics and operations. And again, they may just do some of those, although we think we're having our ECGs and echoes regularly, they might just do additional pre-op. That's great. They're keeping an eye on you, they're planning it well. And as we said at the bottom, you may need a high dependency or intensive care bed post-op. That doesn't mean we think, oh my gosh, this is going to be really bad. We just want it there as a backup. And you're really well looked after there. It's usually 1-to-1 or 2-to-1. So you're in the right place if you've got some additional care that's needed. So that's why we often ask for that. It's not because we think it's going to be drastic. We've done a little bit of work anyway, and we're so used to hearing people have their operations that Victoria would say as well, that we rarely have any issues really, but I think that's because we're planning ahead. We understand that you should be well hydrated, you should be on optimal nutrition. So as long as you're coming in, your anaesthetist will be aware of your condition, but it's minimizing this fasting period. So if they ask you to come in overnight, I know it's a pain, but they may well be doing some of your bloods. They might put your cannula in, they might give you some fluids overnight, so you're really well hydrated. And then what we've always really pushed for is you go down first on the list. So it's no good saying, don't fast. And then obviously, in the old days, you used to, stop eating at, 10 o'clock at night the night before. Then you go in and then you're waiting and waiting and waiting to go down till 5 o'clock in the afternoon. So that's probably when we were having more issues, because your whole body was put under stress. So really good to know that this is a good plan. This keeps you optimized before your operations. So it's something you should be less worried about, because I think, we've learned a lot. And continue your regular medications. Again, just check with your local teams again on that one, because they're very important. And once you come into hospital, they can advise you on that. Victoria, can I have next slide, please? It's probably easier. Thank you. So in the event of illnesses, and again, this is a lot of phone calls we get, is, what do I do? This is not going well. I've had, please can you talk to the ambulance crew? They're right here now. And Some people have said, "I'm in my hospital bed now. The consultants are coming round. Can you talk to them?" And you've missed that call for 5 minutes. You've missed the ward rounds. This is not what we can do. This is you have your GPs. I'll talk a little bit later about the processes we can go through with GPs 111, but this is why we have to try and get you armed with your personal information sheet. We sometimes call this your emergency sheet. That hopefully, if you're carrying that one around, then you say if you fall over in the street, hit your head, go off in an ambulance. It might be that they find this emergency sheet and they know you've got mitochondrial disease, just like your mito card. It's not there to say, use all these numbers in an emergency. I think we've come up against this recently, haven't we, Katie? Where the mito alert cards that you have, the little plastic wallet sized credit card, really should be there really to inform people you've got mitochondrial disease. That I think our wording, we're going to change it, and we're not going to be having something like ring these numbers in an emergency, because we are advisory. So when you're unwell, you've got yourself armed with, you've got your emergency sheet if you need to go into hospital. Ensure that you're trying to keep hydrated. So again, these sickness diarrhea bugs, think about how much fluid you're losing. Just try and sip slowly, keep the hydration going, get some of this diaryite and electrolyte maybe to sip at, to get your electrolytes back again. Eating little and often if possible. Again, we know the cycle of mitochondrial disease. You start feeling unwell, you get nauseous, you don't want to eat. This is the cycle you're going to get into that's going to make you feel worse. So if you're feeling unwell and you're not vomiting, then still try and eat little and often, things that you fancy. Try and find things that you can just pick at. And a lot of people again say, but I'm sat in the lounge, I can't get to the kitchen, or I'm in my bed and I can't get downstairs to get my breakfast. Try and think about having things near to you that are wrapped, that aren't going to go off, and just so that you can sit nibbling, just to get a little bit of energy in you rather than nothing. And this is the problem, it becomes a cycle. Regular paracetamol, and Victoria had talked about ibuprofen as well, if appropriate, if you're struggling to keep those temperatures down. But regular paracetamol, if you have a temperature, just with caution. We were talking about people with liver involvement. And again, just make sure you're thinking about your maximum doses over the day and how much you're taking. Because some of those cold and flu symptom drinks, they also contain paracetamol, so you might be overloading. And again, continue your regular medication if you can. That's the important thing. Diabetic patients, contact your local team for advice. That's always another issue of that we come up against, where people are saying, I haven't spoken to them for ages. It's really trying to get hold of them. If you can't, you're phoning your GP if they're attached to your GP surgery, and just saying, I need my diabetic advice. So please try not to leave it too long just because you can't get hold of them. Find a different way of contacting them. Thanks, Victoria. Next slide, please. So this looks absolutely just very basic, but we have to try and get everybody to think the same, with rather than thinking I need to ring my mitochondrial team or being batted back by GPs or 111. If you have chest pain, shortness of breath, and people do ring us with this, you need to be ringing 999. And obviously, if you're collapsed, any life-threatening emergency, 999 is there. They will triage, they'll get you the ambulance, they'll talk you through what to do. Doesn't necessarily mean that the ambulance will take you off to hospital. They can perhaps assess you, but they're the ones that have got those stethoscopes and blood tests that they can do just there and then. They've got the ECG monitor. So we can't help. If someone rings us, we can't help. We're sat at our houses or in our office at the hospital, and we're miles away from you because you're all so far away from Oxford. The other avenue obviously is 111. Again, this is not urgent medical advice, but this is the way forward to start getting your advice on just those general aches, pains. They will triage you. Again, if you're talking about pain down your left arm or your palpitations, again, they will escalate if they need to. And then they may even ring ahead at the hospital. And get you to go in, straight away at A&E. So there's all these different ways that these people can be helping you. We won't be able to help you because we just can't do x-rays, stethoscopes, bloods, SATS monitors. Um, these are the people that will be able to get you the right help and the right teams. Contact your GP. Now, we've had this as well where people say, they're useless. I can't, poor GPs. I can't get through to my GP. They won't get me an appointment for weeks on end. What's useful, I think, is always having on your notes at the GP surgery that you have mitochondrial disease, because what we say is go and visit your GP earlier than perhaps any other person has in your family because you've got mitochondrial disease. You've got a lower threshold to go and seek medical attention. So if the GPs understand that and know that, perhaps they can put a little sign on your notes so that when you ring the receptionist, they are aware that you're saying, I've only had sickness and diarrhea for 1 or 2 days. I've only had a sore throat for 3 days, because they should then understand that you need to be seen earlier so you can get your antibiotics earlier or get reviewed earlier. So the GP also, sorry, Victoria, the GP also are your prescriptions. So they kind of oversee your prescriptions. Other consultants might be adjusting it, but that's where you're getting your prescriptions from. And that'll all be updated on their systems and your clinic letters go to them. So the GP is really important. It's just finding a way of getting hold of them, getting through past the receptionist to get appointments in good time. Again, if you're having no luck whatsoever, it'll be the 111 or the 999, depending on what the issue is, because you can't just put the phone down and think, right, I can't get hold of anyone. Thanks, Victoria. The next slide. So it was just a reminder of us as mitochondrial team. We're quaternary services, so we are commissioned to advise patients and clinicians. So each centre may operate slightly different. We work Monday to Friday, office hours only, and we do have non-urgent emails to leave your queries. And obviously we'll get back to you when we're able to. And we've probably all got administrators and receptionists that we can leave messages with as well. But we just are not that acute assessment. And all of you, I completely sympathise with the fact you're screaming out trying to get hold of people on phone numbers. No one's replying on emails, and it's incredibly frustrating. But there's a lot of times where we say you do really need to go to your GP. Go and get advice. Go and get them to listen to your chest. Go and get them perhaps to give you some antibiotics. And they will then escalate things if they need to refer to consultants. So they will refer you out to the right services. They're the people that will get you the referrals. OT, physios, there's a whole host of things. So Victoria was always saying that, you're very welcome to invite your GPs and your hospital teams to, our clinical information days or our patient information evenings. Really happy to liaise with them. And now you've got that realization in the earlier slides that you've got some you've got the guidelines, the clinical guidelines that they can access, and you've got the drug list that they can access. So there's things that you can give them. And obviously with your non-urgent email for each of your centres, the clinicians can absolutely contact us and ask the questions. We will get back to them. But as I said, we are Monday to Friday office hours only, and it may take a couple of days to get back to them. But if you're very acutely unwell, you're in hospital, you're in good hands. You've got consultants around you. You've got that A&E team if you're going in straight in, and they're very, very capable. And I think that you often need reassurance that you are being looked after well. And I think you probably don't realise a lot of the comings and goings that go on behind the scenes. So actually, Victoria will have conversations with consultants, but then they might not then give that information back to you as a patient while you're sat there in the bed. But things will probably be happening in the background. Other services just to use, we talked about the pharmacy for the vaccinations, but minor illnesses and things. Urgent care walk-in centres, if you've got those locally, again, to be seen quickly. And just thinking about your other specialist local teams. Yes, we're the mitochondrial, but you've got your gastro teams, neuro teams, there's the mental health teams, palliative care again, hematologists, all of these are their specialities where, we can't advise on those particular areas of your care. And then some people have got open access, that's often the pediatrics. I've got open access to the wards at local hospital, but you'll know about that if you're able to go straight in to the ward. And thank you.